I heard you say high blood pressure. Alright, so what else might you wanna know?
Urine protein.
Protein in urine, how long's it been going on?
Any history?
But, yeah, all good things, all good questions. Alright, this is your assessment. These are your vitals currently, and she rates her headache at 8 out of 10, states when she gets the headache, my vision gets a little blurry, and sometimes I see spots. What's wrong with her? Yes, preeclampsia, probably. Alright, you conduct a physical assessment, you note the following. So lung sounds are good. DTRs are a little brisk, but no clonus. And then she's reported the visual disturbances, right? Alright, so you have these labs. So this is what you would typically see when they want to do a workup for preeclampsia. These are most of the labs that they're gonna order. In the hospital setting, a lot of times on an OB floor, they will just dip the urine themselves rather than sending it to the lab. But the other thing that they may include along with this, it's not on here, is the PC ratio, since we do that a lot more now versus the 24-hour urine. You can do both, but the 24-hour urine, as you know, takes 24 hours. If you just do a one-time protein to creatinine ratio, then you can get a reading off of that. And if it's 0.3 or higher, that is another clinical indicator of preeclampsia. But your Saunders book says this, and I will tell you this, you don't have to have proteinuria to have preeclampsia, but it's more common to have proteinuria with preeclampsia. It is not as common to not have it. So you've got 2+ protein, 1+ ketones, probably a little dehydrated there. Our ALT and AST are elevated, right? I would never ask you on the test, what is a normal ALT and AST? I might give you a question and talk about how it's elevated or it's normal. Because a lot of times, stuff that's not, commonly known, like platelets or H&H or something, the HESI and your NCLEX are gonna give you, reference tables a lot of times. So, her H&H is 11 and 29, and platelets are 125,000, and then you've got the normal values out to the right. So, platelets are down a little bit. We have protein, and our liver enzymes are elevated. So definitely thinking preeclampsia. Alright, so this is the orders you get from the OBGYN. He wants to admit her, do vitals every 4 hours, do a daily non-stress test, check her weight, strict INO. He orders a 24-hour urine, protein and creatinine UA, and then a serum protein and creatinine. He does order Tylenol. It's probably not gonna help, but get it anyway. Saline Lock IV, hydralazine for severe range blood pressures. So when we did SimLab the other day, you noticed probably a couple of drugs that we commonly use with our preeclamptic patients for gestational hypertension, and that's gonna be your beta blockers. So y'all remember beta blockers are your LOLs, right? And then hydralazine and nifedipine. So all of those work a little bit differently. So depending on how well they do, for instance, he ordered hydralazine, but if it wasn't very effective after 2 doses, he might say, well, let's try labetalol now. So you kind of gotta find what works, but you're gonna give it IV for these severe range blood pressure. So that's why he's got parameters there, 160/110, and then to recheck the BP and then administer a second dose. And then to notify him of the PC ratio or any other acute changes. All right, so she's admitted to OB-OBS. The new nurse assumes care, initiates the orders, gives the Tylenol, helps a little bit, still got a headache. Recent vital signs are as follows. And then Carmen's nurse notifies the OB of the PC ratio, most recent vitals, and headache. So what orders would the nurse anticipate based on what's currently going on with the patient? What we need to give her? Magnesium. So she needs mag sulfate because we want to prevent a seizure, right? Now, we hope that it also brings down our blood pressure, but we're treating that in addition with our antihypertensive, the hydralazine. Alright, so they give the hydralazine. After 15 minutes, blood pressure comes down a little bit. The NST results are non-reactive. So this just showing you that the baby just kind of looks flat, like not very active. Don't have a lot of good accelerations in there. Good fetal heart rate, but just very minimal variability. So there's a small little late decel in there too. So the OB comes by to check on Carmen and reviews the non-stress test. What other diagnostic tests could we anticipate if that's non-reactive? Biophysical profile, which is an ultrasound, correct. So the BPP is gonna score different categories, one being amniotic fluid index, one is fetal activity, movement of extremities, swallowing, or, you know, the mouth opening, and then just overall heart rate. So the BPP score comes back 4 out of 8. That's not very good, is it? No. So we're not excited about that, so we may be having a baby sooner rather than later. Okay, so he comes in and talks to the patient and discusses the BPP, and after further counseling, the decision is made to proceed with a scheduled C-section. Why would we want to do a C-section probably and not a vaginal delivery right now?
Because pushing causes her blood pressure to go up.
Yeah, so when you push, you get like 300 to 500 mLs of blood is being like pushed towards the uterus. So what can happen is the blood pressure, if it's already severe range, it's just gonna get worse. So, and I cannot tell y'all 100% that a doctor is gonna say C-section versus let's try an induction. They may try an induction, but if the blood pressures are severe range, typically they may have to go ahead and say, well, let's do a C-section instead, just to prevent any further complications. Now, if they were to induce her, you've got to think about another thing that happens with magnesium and Pitocin. So if we induce a patient and we have them on a Pitocin drip, what's Pitocin gonna do? Yeah, we want it to contract, because we're trying for active labor. Basically, you're doing that Pitocin infusion to mimic active labor. But then our mag sulfate is a smooth muscle relaxant. So what's that gonna do? Relax everything. So they just fight back and forth, the two medications. So typically it's a very long induction process that oftentimes ends in a C-section. I won't say all the time, but a lot of times, okay? So admit to L&D, 7:30 C-section the following day, initiate the gestational hypertensive order set, which every hospital you go to is going to have a specific protocol that they follow. So not everybody's gonna give a 6-gram loading dose. Some of them might start with a 4-gram. But the new recommendations most currently say 6 grams is recommended. Give that over 20 minutes, and then 2 grams an hour with the continuous infusion, and then we'll DC the mag sulfate right before the section. Why?
Because you don't want it competing with Pitocin.
Well, the baby have respiratory conditions, right?
Yeah, it's probably gonna affect the baby either way, because it's been going the whole time, but yes, that is a very good point. What happens after delivery?
That the
If that uterus doesn't contract.
And then you're gonna have.
A postpartum hemorrhage.
Postpartum hemorrhage. So we're trying to prevent a postpartum hemorrhage, so they do briefly discontinue the mag, and then they will start it back. Also, because this patient's preterm, she's gonna get a dose of betamethasone, preferably 2 doses, but if we can get those in, great. Usually they do 12 milligrams, 2 doses, like 24 hours apart. And then we'll initiate the scheduled C-section order set, which has a number of things on it, but mostly it's to keep the patient NPO, make sure we pre-medicate with Ansef or whatever antibiotic that they wanna use, NPO after midnight, and then while she's on the magnesium, this hospital does serum mag levels every 8 hours, some do every 6, it just depends on what facility you're at. And then you'll call in the MD with any acute changes. during the time that she is on the mag, like you're taking care of her for the rest of your shift for tonight before she goes for her C-section in the morning, what things do you need to be assessing,
Neuro,
okay? What about neuro?
like if they're at risk of having a seizure, if they had to have a seizure, are they still like oriented to where they're at and what they're doing?
Good, level of consciousness, what else?
Deep tendons.
DTRs, okay. Would we want her to have at least some deep tendon reflexes while she's on mag?
Yes.
Okay, then we know it's effective. How else do we know it's effective?
If her headache goes
If it
down,
gets better or she doesn't have
No
seizures.
seizures.
It's the anticonvulsant, so that's the main goal with it. What else do you want to assess?
her vision,
Good, vision, blood pressure,
Respiratory effort.
respiratory effort and depth, because it is normal for the patient to feel really lethargic and flush. That central nervous system, everything with the mag sulfate just slows the body down. So we want her to be nice and relaxed, but not so relaxed that she's gonna stop breathing, right? We don't want her to have, respiratory failure, so you go in there and check on her and she's breathing 8 times a minute, we got a problem, okay? So respiratory depth, effort, O2 sat would be included with her vital signs, and also just making sure that, she's, you know, not saying she's short of breath. When you listen to her lungs, if you start hearing a bunch of fluid or crackles in her lungs, you're gonna be concerned too, because what can happen with this?
It moves your fluid.
Toxicity.
Yeah, pulmonary edema, which, you know, but these are all, if we get respiratory depression, if we get fluid in the lungs, if we have absent DTRs, minimal to no urine output, we're worried about mag toxicity, right? So how much urine output is normal?
30 milliliters an hour.
So as long as we're having that, we're considering that okay. But we always look at our patient, and then we'll do those mag levels. And the mag levels, because we are giving mag sulfate, it needs to be between 4 and 7 as a therapeutic level of the medication. We're not talking about just the normal mag electrolyte in your body. So we need this to be higher, right, to keep that central nervous system depressed. So now if the mag level's 5, but she has all these symptoms of toxicity and no DTRs and respiratory depression, no urine output, we're still gonna call the doctor and he's probably gonna stop the mag or cut it in half, okay, because they're ready to have. Because, just because the number doesn't say we're toxic, doesn't mean that's not toxic for her. So everybody's gonna metabolize it a little bit different, right? And some people are sicker than others, and if their kidneys are really bad off from preeclampsia, like if they've done a lot of, if it's caused a lot of damage already, they may not be able to put out a lot of urine, to get rid of that. Alright, so she's prepped for a C-section, mag sulfate infusion is DC, spinal anesthesia is administered. Typically, if it's a scheduled C-section, depending on the facility and the anesthesiologist, it's gonna be a spinal. Unless it's an emergency section and we don't have time to do a spinal, then we would put somebody under general anesthesia. It is much better for the patient if we have time to do a spinal, because they're gonna have that gradual, you know, the feeling will gradually come back versus you just waking up and being in a whole lot of pain. So he performs a C-section, newborn's handed off to the nursery nurse. Estimated blood loss, you still see that a lot in doctor's notes, but a lot of times what you see now is you'll see EBL and then you'll also see QBL. Because the nurses in most facilities now have it built into the chart, where they can actually measure the QBL by measuring the pads, and then they have the dry weights of the pads, and then they deduct the dry weights of the pads. The nice thing when you measure blood loss is 1 gram equals 1 milliliter of blood. So it's, most of your pads and your items that you're using are gonna be weighed in grams, so it's easy to convert that. Just don't forget to deduct the dry weights of the pads. Primary nurse starts the IV mag sulfate back at 2 grams an hour. Usually it's mixed in LR. 2 grams an hour essentially comes out to be 50 milliliters an hour. And then a second IV line is infusing with 30 units of Pitocin at 42 cc's an hour, because we're always gonna give Pitocin after delivery as well to make sure that that uterus stays contracted. We'll still be watching out for a hemorrhage though, because now we've got the mag going again. So she's transferred to recovery, notified the status of her newborn, transferred back to her room on L&D while she is on MAG. So essentially, because these patients are more high risk for seizures and we're doing a lot more frequent assessments, we're going to make them more of a one-on-one patient. There are some facilities where we would take care of them on a mother-baby unit. I used to take care of them on mother-baby, but then I could only have one other patient. So for staffing's sake and for the sake of they want mother-baby nurse taking more patients, they'll keep that MAG patient, and she'll be one-on-one, which is important because we wanna keep them safe and make sure we don't have any complications. So how do we prep the room?
Calcium gluconate and seizure kit.
Okay. Yeah, with the side, had the side rails, and you already had
Suction.
suction at bedside,
Oxygen.
oxygen ready to go. So just safety, think about seizure safety precautions. Let's see. All right, so let's go back and talk about preeclampsia one more time, and tell me one of y'all, tell me what preeclampsia is.
Chronic high blood pressure after 20 weeks.
That's gestational hypertension, but it's part of that. What else?
And with proteinuria,
With
usually.
proteinuria, could have low platelets. If we progress even more with the body systems, like let's say the platelets drop even lower and the liver enzymes go even higher, and we start having hemolysis, then we can go to HELLP syndrome, right? So another not so great complication. So just want y'all to understand, it's just a vasopressive disease, okay? And it has to do with how the placenta implants and those arteries are implanted into the uterine wall. Now the hope used to be that, oh, this was the cure, if we deliver the baby and the placenta, everything's good. But we know that's not the case anymore because we have patients come back in with postpartum preeclampsia. So even though that placenta is delivered, still have some vasopressive disease going on and some vasoconstriction going on. The MAG is the gold standard treatment for preeclampsia. It's also going to help because it's a central nervous system depressant. It's gonna vasodilate those cerebral vessels and hopefully help that headache as well and stop all that vasoconstriction. The hope would be that it does well enough for the patient that they don't end up seizing, or in worst case scenario, they could end up having a stroke. So this is why when you send a patient home, even if they didn't have problems during their pregnancy, you should still be discussing this with them at discharge, the potential for complications to occur, especially in that first week. So you still wanna warn them about severe headaches. You don't wanna sit there and tell them, oh, you should check your blood pressure every couple of hours, because maybe that's not necessary, but you do want to talk to them about the potential. Now, some physicians will ask patients that have preeclampsia during the pregnancy to go ahead and get a blood pressure cuff for at home. And I know most of the time you can buy them at drugstores. I don't like them. I feel like they always quit working when you need them to work. Even, I don't know what the deal is with the ones at home, but I like the manual ones better. So lots of education is important, and making sure that you guys understand how MAG sulfate works. What are the side effects that we would tell the patient to look for, which would be the flushing, the lethargic feeling, the warm feeling, basically a feeling of, I don't care. Well, I just had a baby, but I do not care. So it's nothing against them. You just have to explain to them that it's the MAG, because a lot of times they'll get upset later and say, well, I don't know what happened, but I just didn't even want to hold my baby yesterday. Once the MAG gets out of their system, they'll feel a lot better. But it's gonna run for about 24 hours after delivery.
When you send them home, will they take any kind of supplements or?
Depends. So, good question. So, if their blood pressure remains high, because again, MAG is not necessarily for the blood pressure, we might be giving them hydralazine, labetalol in the hospital. We might even start them on Procardia by mouth. So if we start them on something like that and their pressures are still slightly elevated, the doctor may send them home with some and tell them to come back to the office in a week to do a blood pressure check. They'll also give them the education that you would as the nurse about severe headaches, if you feel like your swelling is getting worse, especially in your face and hands, that you need to come back in. So It depends on how bad the blood pressures are, if they need to send them home with something they may. Also, a lot of times when they're preeclamptic during the pregnancy, or let's say they had a history of preeclampsia and they're pregnant again, the doctor may preemptively put them on some baby aspirin, because there are some studies out there and research that shows that it helps prevent, doesn't completely prevent, but it can help prevent or reduce the risk of developing preeclampsia. Good question. Any other questions about that? Alright, we're gonna talk about Kylie Smith. So she's 16, G1P0, she's 30 weeks pregnant. She reports having intermittent low back pain and abdominal pain for the last 3 hours. So what are we thinking with her?
Term labor.
Preterm labor. How do we know if we're in preterm labor? What do you need besides contractions? Cervical change. So we shall see. Alright, so this is her fetal heart rate strip on admission. Normal baseline, and she is contracting, but the baby's not really having much variability, but she is having regular contractions. Alright, so she gets some orders. Admit to L&D, continuous fetal monitoring, vital signs Q4. Do some basic lab work in the off chance that if we have a baby early, we already have these things done, like a CBC, a type and screen, and a metabolic profile, just to kind of check and make sure this isn't just a case of I'm really dehydrated, because how many people do you know that drink the correct amount of water in a day, pregnant or not? I know I don't. So bed rest with bathroom privileges. So a lot of times we don't do strict bed rest. And one of the students in the day class was like, well, I thought it sounds extreme to say bed rest with bathroom privileges. No, extreme would be if we said complete bed rest, you can't get up at all, you have to have a Foley. We wouldn't do that because of the risk of developing DVTs and other complications that can occur. So we're at least gonna let them get up and go to the bathroom when they're in the hospital, and it depends on the patient too and how compliant they are. If you know that that patient has 4 other kids at home, do you think they're gonna lay around? No. They might want to, but they can't. So, also, like your patients that work a job where they're on their feet all day, these are the patients that you may put out of work. And, they may have to just be at home. So if they can't be compliant at home, sometimes they get stuck in the hospital with us, which is not fun to be stuck in the room for weeks on end. Terbutaline is a tocolytic, and we give that sub-Q. We give 3 doses of that every 20 minutes. And those are the max doses we give to see if we can get those contractions to stop. So they're hopefully going to stop the uterus from contracting, so everything kind of calms down. Alright, badge exam for presentation, dilation, and effacement to see if she is dilated. The hope would be that if she's not, then we could just watch her after the terbutaline. If everything calms down, she could either go home or be observed for several more hours and then go home. Now, if we're concerned about preterm labor, we will preemptively give Celestone, same thing as betamethasone. We'll go ahead and give a dose now, and we'll go ahead and consult the neonatology department if we have one available in our hospital. Because we know that if we can't get labor to stop, then she's not stable enough to transfer to a higher level of care. So we're gonna have to have the baby here. Alright, so this is what a normal terbutaline label looks like. So how much will you give? If you're giving 0.25 milligrams, what would your dose be?
0.25.
That's right. So what teaching should you provide to the patient that's taking terbutaline? What kind of side effects do you see with that? Okay. Tachycardia, that's right. So sometimes it can raise the heart rate, and actually it'll raise the baby's heart rate as well. So something to keep an eye on and to think about. So you should assess heart rate prior to administration, both maternal and fetal. And how will you know if it's effective? How do you know it worked? contractions stop or either decrease at the very least. Alright, so why are we giving Celestone betamethasone? What's that for?
To speed up development.
Help with fetal lung maturity, right? Because if we do end up having the baby early, we would like to not have to do as much, resuscitation with them, which likely we still will because they're only 30 weeks. They start producing surfactant at about 22, 23 weeks. When I say they start, that doesn't mean they have sufficient amounts. Sufficient amount is usually between 34 and 37 weeks, okay? That doesn't mean that a 37-weeker won't come out and you won't see the neonatologist still give them surfactant if they're in respiratory distress. Usually if they're in true respiratory distress, surfactant is gonna be the first drug that the baby's gonna need. But we'll give this steroid in hopes that we don't require as much surfactant, or if the mom was further out in her pregnancy, maybe we won't require any.
Would you ever test amniotic fluid, or is it too far along?
If you have a patient, like this patient, that's just the one I made up, but if you have a patient that, let's say they have all their babies preterm, and you know they have a history of that, this is baby number 3, so that person is typically gonna be followed more closely, and they'll be offered, the test to check the, LS ratio, and I'm not gonna say those long words, cause I can't ever say them correctly without mispronouncing something. But if they look at the LS ratio, it should be 2 to 2.5, and that, should equal lung maturity. If it's not, if it's lower than that, you're probably not ready to deliver. But again, that would be like someone that had multiple preterm deliveries, and we already know ahead of time, and we're checking those things on the front end. But this is first baby, it just depends on the doctor. And it depends on who you got around you. Do you have a maternal fetal medicine doctor? We had a really good one at East Alabama, and she ended up having to move, so now we have to send the patients that come there to the MFM in Montgomery. So, good question. So where are we gonna give this? What site?
Vastus lateralis.
Yeah, just a large muscle, and typically that's the easiest thing is the vastus lateralis. That medication is thick and it hurts. So that's why you need it to be in a large muscle. And it is no longer recommended to give things in the gluteus medius. You can do ventral gluteal, but sometimes it's harder for y'all to find landmarks that way, and if somebody's laying in the bed, it's much easier to get to their vastus lateralis. Alright, she gets the 3 doses. Her contractions have decreased and she reports feeling better. Physician writes the following orders: repeat the vag exam. If no change, transfer to the antepartum unit. So some hospitals will have separate units for antepartum versus an OB triage patient who we're not sure where they're going, or they'll have an OB-ED, and then you'll have like the labor and delivery units and everything. So she's getting NSTs twice a day, regular diet, so they're gonna let her eat now that they've stopped at the labor. Vital signs Q4 and nifedipine 10 milligrams PO Q6. Why are we giving Procardia for that? So, what now?
It causes tachycardia.
So nifedipine's a calcium channel blocker, and it's another medication that actually will, relax the smooth muscle of the uterus. So it will help decrease uterine irritability. I can't talk today, irritability. So nifedipine, give it in a lower dose. So, you know, you see there it's 10 milligrams. Usually that's about normal for preterm labor. Sometimes they'll do 20 milligrams. But if you're giving it for preeclampsia or high blood pressure, you're gonna give like 30 to 60. So this is gonna be a lower dose, just to continue to keep those contractions down. And bed rest with bathroom privileges, which you also could see that in other places when you're reading up on this. It could say modified bed rest, which just essentially means, yeah, you can get up and shower and go to the bathroom, but you don't need to be doing piles of laundry and being on your feet all day. You also may see like patients with this and placenta previa, they'll tell them pelvic rest. What does pelvic rest mean? No sex, nothing in the vagina. So they may do that as well. So this is her next NST when she's on the antepartum unit, and that's what we prefer to see. No contractions and good accelerations in the heart rate. Another risk factor for preterm labor that happens more often during pregnancy is UTIs. So if we think about when we're pregnant, how much pressure is being put on the bladder as the uterus is growing, you notice, if you've ever been pregnant, you get up and go to the bathroom and it's constant, but you may not be completely empty. So a lot of times that urine, some of it is sitting in the bladders causing urinary stasis, and it can build up bacteria. So if we get a UTI, it's important that we educate our patients when they're pregnant to report those symptoms, because if they don't, then they could develop that uterine irritability from the bladder, irritate the uterus, and start having contractions. So lots of fluids, lots of, keeping an eye on pain, whether it's low back pain or abdominal pain. Usually contractions, you would have to have greater than 6 in an hour, and you have to have cervical change to be in preterm labor. Okay, so you have to have both things going on. But you're not gonna know if you have cervical change until you come in. Make sense? All right, Maggie Pate. So you're the labor and delivery nurse. She's being admitted for induction of labor, and she is 40 weeks and 5 days today because she was offered induction earlier, but she said, no, I don't want to, I want to go natural. Good for her. But she also has gestational diabetes. What do we know about gestational diabetes?
It makes bigger babies.
It can. What else?
The babies can come out with hypoglycemia.
They can come out with birth defects, hypoglycemia. They can even die if the sugar is, if the glucose in the mom is very poorly controlled. And how severe is the diabetes? And you have some patients that already have type 2 diabetes or type 1 diabetes, and those babies are still at risk of hypoglycemia at birth. With gestational diabetes, when you take that nasty glucola stuff, when you're about 26 weeks pregnant, it's called your glucola test, glucose tolerance test. If your glucose is less than 140, you're in the clear. If it's 140 or greater, you could have gestational diabetes, but we'll also offer you a 3-hour test. If that 3-hour test is still 140 or higher, you get the diagnosis of gestational diabetes. And sometimes I think that, I know you see patients that they didn't get a diagnosis of gestational diabetes, and they come in and have a 10-pound baby and the baby's blood sugar's 12. And they'll say, no, and they may have very well passed their glucose tolerance test. Don't just not believe some of them probably did, but later on they developed it, or maybe they were borderline and the doctor didn't give them any further instructions to watch their diet or anything, and they just kind of, because I don't know about anybody else, but I had a free-for-all when I was pregnant. So I'd have been screwed if they said you have gestational diabetes, because I was eating whatever I wanted, whenever I wanted. So it's really important that, the patients get educated on that. So she denies any other medical issues. Prenatal labs are there. Anything that we're worried about with the prenatal labs? She's A negative, so she might end up getting some Rogaine, depending on if the baby's positive, right? And we're already concerned that we might have a large baby, right, because of our gestational diabetes. So, do y'all remember talking about this last semester, a Bishop score? It's not something you hear about a lot, but for some reason, they still talk about it on HESI and stuff. But basically, they're observing the cervical condition, and the physician is doing that and giving them a score. And that's another reason you don't hear about it a lot. It happens more often in the clinic setting with the physician versus in the hospital. So, because the doctor's gonna go ahead and determine whether or not they think that this patient's a good candidate for induction before they admit them, for induction. So they look at these parameters, they look at, cervical dilatation, cervical length, consistency, position of the cervix, and station of the head. So when I think about station of the head, do y'all remember that from last semester? So if we're negative, that means our baby's really high, right, above the ischial spines, above that pelvic inlet. If we get down to 0 station, then that's a good thing. That means we get a higher score because we're closer and we're able to descend better. If we're still -3, we're way high, and what you'll hear a lot of times in the hospital is, oh, she's close, thick, and high, not a good candidate for induction. So if she's not a good candidate for induction, sometimes they'll still induce because she's post-states, but they'll give a medication, dinoprostone, or commonly known as Cervidil, is a vaginal suppository, they can give that, and it will thin out the cervix, we hope. Or there's a Foley bulb that can be used, it's called a cervical balloon actually, but they call it a Foley bulb induction, and it mechanically dilates the cervix. It is inflated with anywhere from 40 to 60 cc's of saline. So if you think about when you put a catheter in the bladder, you only put in 10, right? But you're putting one in the cervix and you're putting pressure there to push and force, mechanically force open the cervix. Not comfortable. So, glad it wasn't popular when I had a kid. But they're much more popular now, and they do work well. They have good success with them. Things tend to progress better because it will typically, that Foley bulb will mechanically dilate the cervix to about 4 or 5 centimeters. And then hopefully it'll fall out on its own, or the nurse will go back and take it out, and then that'll help progress things along with putting the patient on Pitocin. So she's on Pitocin. Her last badge exam was 2 hours ago. She was 6 centimeters, 90% effaced, -2 station, with caput noted on exam. Y'all remember last semester when you learned about caput versus cephalohematoma? What's a caput?
Crosses sutures or?
Yeah, crosses the suture line, so just fluid. And the reason this baby's having some caput is because it is trying to descend and it's putting some pressure there, so some fluid is building up. Typically nothing to worry about, it'll reabsorb, but it lets you know that that baby is trying to come down, but because it already has caput, it might be a big old head. So, we're not excited about that, right? Because remember you said we were worried about a large for gestational age baby. She's got her epidural infusing, so thankfully for her, hopefully she's not feeling any of that. And then these are just the lactated ringers, oxytocin. This is what the normal drug label looks like. It's typically gonna be added into a bag of either 1,000 or 500 mils. Her husband's at the bedside. Her last finger stick blood sugar is 102. Remains NPO except for ice chips and popsicles. Vital signs are within normal limits. Foley catheters there at bedside. Normal drainage. She denies any allergies. These are her lab results currently. So fetal heart rate looks good, moderate variability, contractions are regular, strong on palpation, good resting tone, meaning that we have good rest between contractions. Where, contraction length shouldn't be more than 60, max 80 seconds. If it's 90 seconds or longer, where you don't have enough time for the uterus to relax and the baby to get a break from being squeezed, for everything to kind of go back to normal, so the mom can actually, hopefully not have a uterine rupture. So if you continue to have contractions really close together and you don't have rest time in between, you increase your risk of uterine rupture, and then that's called tachysystole. Maggie states her pain is adequately controlled with her epidural. LR is infusing. This is her 3rd bag of fluid. They get a lot of fluids, especially on the front end before they receive the epidural. They're going to get a lot of fluid because what do we worry about with epidurals?
Hypotension.
Maternal hypotension. What drug do we give if the blood pressure drops low?
Epinephrine.
Ephedrine.
Oh,
I know,
Fed.
people always confuse it. Ephedrine, yes, correct. All right. So this is her fetal heart rate tracing. So we're getting close. Don't know how I feel about those. Labor continues to progress. Some of these pictures are old. Maggie has been pushing for 2 hours and the head's delivered. But the shoulder stuff. So what are we gonna do now? What's that called? What maneuver?
Mick Roberts.
Mick Roberts. Mick Roberts maneuver. So what does that entail? What will we do?
Bend all the way down, her shoulder or her legs back.
Back here. Yeah. Yeah, so we're trying to open up that pelvis as much as we can, like you said. Push those legs back as far as they'll go, not just sit them in the stirrups. And then the labor nurse will perform suprapubic pressure with her fist. Thankfully, this patient has an epidural because that's not comfortable either, but you're trying to dislodge the stuck shoulder from under the pubic bone because that's typically where it's getting stuck. So if you can do that with the suprapubic pressure and opening up the pelvis, then the hope would be we get that baby out as soon as possible and we decrease the risk of having a hypoxic brain injury, okay? So shoulder dystocia doesn't need to last longer than 45 seconds. There are some that last longer than that and babies still, their outcome's still great. It just depends on the baby, right? And it depends on how long we went where we were possibly asphyxiated or hypoxic, okay? So typically when those babies come out, they're still gonna have to be evaluated closely. They can't just go right skin to skin. So we're gonna need to make sure that they're not completely stunned when they're born, because a lot of times they are, they're not breathing well. So we already talked about newborn complications. What maternal complications can occur due to shoulder dystocia? Tearing. What else? Hemorrhaging, yeah. Hemorrhaging and tearing. So typically the other thing that will occur when you're doing the Mick Roberts maneuver, the physician's gonna be down there probably doing an episiotomy, even though those are not routinely recommended. They are in cases where we're worried we can't get this baby out in a timely manner. We don't want the head just chilling there and the rest of the body not out. So a lot of times they'll do like a medial lateral, like kind of to the side, but most of the time just a medial cut there and do the episiotomy. And they do some internal maneuvers. You're not required to know those, but there are all kinds of names. Zabanelli, some other ones, but you don't have to know that. What y'all need to know is Mick Roberts, because that's what you're doing as a nurse. All right. Placentas delivered 10 minutes after her newborn. She's allowed to briefly hold him, move to the radiant warmer for further evaluation. Apgar scores are 6 and 8, not terrible. In real life, she probably wouldn't even hold him. They'd probably just hold the baby up and say, here he is, and then boom, we're over in the warmer. So she has a 2nd-degree episiotomy, which the physician is repairing, while the Pitocin is being bolus, because we're always gonna bolus in half of that 30-unit bag. And then we have estimated blood loss of 500, which, how much is too much for vaginal delivery?
500.
Anything over 500, and how much for C-section?
1,000.
Anything over 1,000, okay, so we'll be keeping our eyes on her. All right, nursing assessment reveals the following. What do we do about a boggy uterus?
Massage.
Keep massaging. When in doubt, massage the fungus, right? So keep massaging. Sometimes when you're massaging, it will firm up, and then immediately when you stop massaging, it'll go back boggy. So if you're the nurse, you're kind of stuck there massaging the fundus, and hopefully having a bunch of other people come in there to help you, because her pad's completely saturated, so those will need to be weighed. We have something called a postpartum hemorrhage cart at most hospitals now, kind of like your crash cart, but just for postpartum hemorrhage. It's stocked with pretty much everything we need, which is great, because then you're not running around or having other people run around and grab you things. So anything from supplies to do an additional repair, if there's additional laceration, or if we need to do an exam, we've got speculums in there, extra IV start kits, extra fluids, medications for hemorrhage. So all that stuff is usually in there, along with a scale on top to weigh the pads. So she states she's feeling a little dizzy when she's sitting up in bed. Definitely not getting her up right now, okay? What nursing interventions would be appropriate right now? of times we'll fluid bolus.
With the physician there?
Mhm.
Check her mag.
Start back Pitocin.
She's got Pitocin going.
Well, we already said it's artificial fundus.
Mhm. What sits in front of the uterus?
I would check her
During the, bladder.
bladder.
Yes, so either we could straight cath, or we could catheter, and if we get more than like 600 mils out, we'll leave the Foley in. And that depends again on your protocol at your facility. But if somebody's putting out a ton of urine, it's best to leave the Foley in versus just straight cathing, because you don't want her bladder to fill again quickly and her not be able to pee. She's not gonna feel to pee for a while after having an epidural. So I wanna make sure we keep that bladder empty. Here's some additional orders. So, another 500 ml bolus, she gets Cytotec, or misoprostol, which is the name y'all need to know, 800 micrograms rectum. So the thing about, Cytotec or misoprostol is it only comes in pill form. So if you've ever seen it given by a nurse or a physician for hemorrhage, you just see them putting 4 pills in the patient's rectum, and you're like, why are you putting pills in their rectum? That's because that's the only way it comes. So, but in SimLab, we have a fancy suppository that we use. It's like magnetic, and the computer will actually tell me that y'all put the Cytotec in, so. But yeah, I don't know why it only comes in pill form. So stat H&H, this is what we have here. So, she had a 10-point drop in her crit, and then she had quite a drop in her hemoglobin. What do you think we'll be giving her later? Yeah, probably so. Alright, so, if we have too much bleeding and we give medications such as Cytotec, misoprostol, or let's say we give methylgonervine, Methergin, or carboprost, which is Hemabate, there's certain things we need to know, right? So with our Hemabate, we're not gonna give it to patients that have asthma, because your carboprost is gonna cause bronchospasm. You're not going to give Methergin if somebody's blood pressure's already through the roof. And then you also need to know that Hemabate's gonna cause, diarrhea, so Imodium would be nice to give to the patient. Cytotec can cause some diarrhea too. So just FYI, that table I made with the drugs, it tells you all that, so it's all the medications are in one spot to look over those. Alright, let's talk about Miss Annie Walker. She's 27 weeks, G3P1, comes to the labor and delivery unit complaining of severe abdominal pain. Says she's having some vaginal bleeding. So you put her on the monitor and this is what you see. What'd you say? Alright, placental abruption. I've never seen a sinusoidal, actual classic sinusoidal fetal heart rate pattern, which to me, if I'm thinking about heart rate, it kind of reminds you of a flutter. But typically you'll see some D cells as well, some late D cells, just letting you know baby's in distress. But if you get a sinusoidal, you know there's like severe hypoxia going on. And sometimes these patients don't bleed because they're having a concealed abruption. So they might come in and say, I'm in severe abdominal pain, and they have a hard, rigid abdomen, but they don't have like frank bleeding. If they've got frank bleeding with all that, they definitely probably have an abruption, but you still have to diagnose it with an ultrasound. And sometimes because they're small and concealed, and the placenta hasn't completely torn away, may not notice it until delivery. Alright, physical assessment, rigid abdomen, moderate amount of bright red bleeding from vagina on peri-pad. These are her vitals. Stat ultrasound. And what are we gonna do after that ultrasound?
Get ready for a C-section.
Prepare for a C-section, because this is emergent. So, admit to labor and delivery, stat H&H, type and screen, stay ahead 2 units, because we anticipate some blood loss, may have some blood loss in the baby as well, so the neonatologist will need to know about this baby. Stat cesarean section, and then notify NICU, because the baby can come out with some hypovolemia as well.
We'll stay ahead 2 units.
Hmm?
Stay ahead 2 units, what's that mean?
Stay ahead 2 units PRBCs, that just means stay ahead 2 units packed red blood cells, meaning always keep at least 2 units on hand and ready to go. You know how, blood banks will be short, they don't necessarily keep some held to the side for a particular patient, you would just ask for that ahead of time, just anticipating that you may need it. Stat C-section, neonates handed off to the neonatologist. Our quantitative blood loss is 1,500, so more than we would like it to be. Vital signs, she's a little tacky, blood pressure's a little low. Fundal massage expresses 1 plum-sized clot. Small bleeding is observed on the peri-pad. So, in all honesty, her uterus is fine. 1 plum-sized clot is not necessarily something to worry about. If we continue to get clots every time we massage, that would be an issue, okay? And you'll see, clots, the size referred to like fruits, like orange size, grapefruit size, those are bad, obviously, but or golf ball, you'll hear sometimes they'll say that. Nurse notifies Dr. Smith of the current vitals and assessment. Okay, she's transferred back to her room, firm midline 2 below, bleeding is small. It's not uncommon that she would already be 2 below, especially if she wasn't completely term and she was having an abruption. So her vitals are pretty stable right here, and it is important to know, even if she has significant blood loss, they may wait to do a blood transfusion if she's clinically stable. So they're always gonna look at the patient. A true abruption, you're gonna need to go ahead and give blood. But if you had something like a partial abruption and your hematocrit didn't drop that low, they may wait to do blood or just offer it to you. So it just depends on the patient. Cause y'all know if you've been to a med-surg unit, you don't mess around with older patients, right? When their hemoglobin's down, they're getting a blood transfusion every time. That's not the case with most patients that are otherwise healthy that are pregnant. But with an abruption, you're typically, if you've got that much fluid loss, 1,500, you're gonna be getting something. Post-op day 1, here's your vitals, here's your pre and post. So again, pretty significant drop. So we're gonna anticipate hopefully some whole blood or packed red blood cells. And then if worst case scenario, let's say it didn't drop that much. Let's say that post was 8 and 23. We might also see the physician offer an iron infusion, okay? But odds are if you lose that much blood, you're gonna drop lower than that. And some patients we've seen that hemorrhage over 3,000 milliliters, they're definitely getting some blood. They may even be getting some FFP or platelets or whatever. Alright, so placental abruption, hard rigid abdomen, severe abdominal pain, frank bleeding, right? Placenta previa, non-emergent, will have vaginal bleeding, but it's usually not severe, and we don't have pain, it's painless bleeding. Okay, so that's how you differentiate the two, because they like to compare those a lot. Alright, this is Sarah. Okay, so she's 32 G2P1, she's 36 weeks, she's admitted to OB-OBS for DFM. DFM means decreased fetal movement. She comes in at 8 a.m., she states she's not felt the baby move since around 6 p.m. last night. So if we ask a patient, if a patient calls and says they haven't felt the baby move, we'll ask them a lot of times to do some kick counts for us, and they should feel at least 10 every hour, or at least 10, even if they're not huge movements, because we know the closer to term we get, the less room the baby has in there, but we should still feel at least 10 times in 1 hour. If we're not feeling that, we'll have them come in. So upon assessment by the nurse, she notes no pain or vaginal discharge or bleeding. But she does get a bedside ultrasound, and there is no fetal cardiac activity. So they're obviously very upset. I go back through these because I don't, when y'all go to clinical, it's not usually a good idea to put a student with someone that has a fetal demise, but it is important that y'all understand what happens with these patients and what we do differently for them and how we, try to, give them as much, time as possible with their baby. Have something called a cuddle cot to keep the baby cool, so that the baby can stay in the room with the parents as long as they want. So if they're upset, obviously. So what would be the priority nursing action after confirmation of the IUFD, intrauterine fetal demise?
B.
Stay with the patient. So sometimes when bad stuff happens, I mean adults or babies, we can say things that we don't mean for it to come across a certain way, or we're just not good with therapeutic communication. I mean, some people are not, and that's okay. So when you don't know what to say, it's okay to be silent. It's okay to say, I'm so sorry. What can I do for you? Sometimes that's all I say, because you definitely don't wanna say things like, it was God's will, or you can always have another baby. Like, just don't say that. Just say, I'm really sorry, what can I do to help you? And sometimes all they want is somebody to sit with them. We never want them to go home and encourage them to grieve privately, because that's not a good way to cope, right? And you're gonna grieve the same way you grieve any other loss. You go through the stages: denial, anger, acceptance, all the things. Provide information about funeral arrangements. At some point, we will address this, but this is not right when they find out. It's not appropriate. And we're not gonna just jump on Pitocin and induce labor right away. Which statement best demonstrates therapeutic communication by the nurse?
D.
Yeah, D. So that lets that patient know you're there to be supportive of them, whatever it is that they need, and that you understand it's difficult for them. Sometimes those of us that are nurses may have gone through similar situations. Don't always bring these up, usually, unless the patient continues to wanna talk about it. And you kinda have to just gauge, would it be appropriate? But you try to empathize with them, but if it's never happened to you, you don't really know what to say, so just, this is difficult, and I'm sorry, and I'm here with you. All right, appropriate nursing intervention during the labor and delivery process for Ms. Adams.
B.
B. So, different facilities have different things that we provide locally within the community, so I'm sure Georgia has some different things that they can provide. We have some, a woman that comes and she does, it's called Now I Lay Me Down to Sleep. She does photos free of charge, for the family, and she'll have those available and can come and do those when they're ready. There's also another woman in, the Opelika community that does something called patty cakes, and she'll do hands and feet on a ceramic plate, like the molded, and then she'll have that for them as well. Usually at the hospital, you provide something, whether it's a bear or a box. We have a little box that has some mementos in it. If the baby was further along, close to term, we might have a lock of hair in there. We'll have a little outfit that will dress them in from things that have been donated, usually by churches. And you gotta think too, if you had an earlier loss, you need like a little small gown, so we'll have that, and we can put that on the baby so they're not just there naked in a blanket, and that's something they can take home with them too. And we'll usually put a sign on the door, and we'll try to put them far away. If we can, we'll put them, on a different unit, maybe like an observation unit where there's not a potential for them to hear the baby crying. Or, I know when they would come over to Mother Baby, we used to just put them in a corner room, so they're way kinda off away from the other people that their babies are crying. So the cuddle cot, what's that do? Y'all ever heard of it?
Cool.
Yeah, so just keep, it's kinda like, excuse me, sorry, have you ever seen a K-pad? Like, or you don't know what a K-pad is, so it's hooked up to the little pump that pumps fluid through, water through it essentially, but it's warm. This is like a K-pad with just cold water. And if it works well, which most of the time they do, if we're not having to send the thing back to be worked on, it keeps that mattress cool, so we'll place like a blanket over the actual K-pad itself and the baby can lay right on that. And that way, we'll have them in like a Moses basket or a bassinet, and it'll be on wheels so we can have the little machine for the actual cuddle cot to work. We'll have it there so they can stay at the bedside as long as they want to, instead of us saying, I know you've been with the baby for a while, but it's probably best if I take the baby to the morgue, and then you can have the baby back later. And we didn't wanna do that, like back and forth. Nobody wants to do that. You wanna be able to spend as much time as you can. It also depends on how far along the baby is as to how, physically, like how their skin is. Obviously, it's a little more translucent when they're only 20-something weeks, so their skin may weep a little bit more than a term baby would. So this just maximizes the time that they can have that baby with them. All right, so what discharge instructions are appropriate after a fetal demise? B and D.
That's all I got for
Right, because, after you have a baby, when are you supposed to have sex?
6 weeks.
Yeah, so it doesn't matter if it's a loss or not, it's gonna be at least 6 weeks. Lactation suppression is important, because that's gonna be a tough thing to go through too. Because even though there is no live baby to go to breast, your body will tend to just produce milk about day 3 or day 5. And so getting a good, like, supportive sports bra. We used to bind their breasts, some places still do. It's not really recommended anymore, but like a good tight fitting sports bra, maybe some cabbage leaves that actually, draws out the, there's something in cabbage leaves that helps dry up the milk. So I know it sounds weird, but it works. Birth control options, you can. I mean, that could go either way, I think, but I feel like for this one, just doing the lactation suppression, referral to a grief support group. We're not gonna avoid discussing the loss with the family, but you do kind of gauge, like y'all have already talked to several patients by now to know who's a talker and who's just gonna be stoic. Because there are patients that never show emotion. They're waiting until they get home to fall apart, and they will not fall apart in front of you. It doesn't mean they care less, it's just not everybody copes and grieves the same way. So it's important to know that too. I think it's okay to show emotion to your patients. Sometimes they get you all teared up, and that's okay, but you don't need to be so emotional that you can't function and take care of them because you're boo-hooing and they're not even crying. You know what I'm saying? Like, you've got to maintain a certain level of professionalism, and if it's your very first loss with a patient, you may not be able to. You may have to go to the charge nurse and say, can someone else take care of them? Because I can't. So sometimes it is difficult. All right, y'all take a potty break.